Microelectrode recording during DBS or deep brain stimulation procedures for movement disorders. We're going to focus on three structures of which we were going to go over some of the microelectrode characteristics of these structures. They will be the GPI, globus pallidus internus, VIM, ventral intermediate nucleus, and STN, subthalamic nucleus. We will first start with the GPI target. Here's an example of a DBS electrode placed in the globus pallidus internus. This is a slice out of the Schottenbrand and Warren stereotactic atlas that's 21 millimeters off of midline. These are the GPI structures in both the coronal, sagittal, and axial views. The first structure that we encounter if we start high enough is the striatum that consists of two nuclei, the caudate and the putamen. There tends to be no spontaneous activity in these structures. It's really activated by the electrode passing by. It has a very sparse cell distribution. It has two basic cell patterns, single spike cells and X cells. In primates, recorded trains of spikes in the striatum have been locked to the onset of movement. Here's an example of a single spike cell with some X cells that you will see in the next few slides. These have firing rates of 0.1 hertz to 20 hertz. Frequency of spikes are low. And during microelectrode recording, we're most likely recording the spinal neurons in this structure. And here's what these sound like. The next cells that we may encounter, and this is in all structures, are X cells, and these represent cell death. The microelectrode has either banged into it or broken the cell membrane in some way, and the cell is just firing as it's losing its internal structure. It has a high discharge rate of decaying amplitude modulation and sometimes a decaying frequency modulations. These delays can last from milliseconds to seconds. We then come to the external globus pallidum that lies medial to the putamen. It lies lateral to the GP, I and E and internal capsule, and there is a thin lamina between the putamen and the GPE. The cellular activity once we get into GPE is spontaneous. It helps us differentiate the striatal structures from the GPE structures. The background activity, there is spontaneous activity, and there are two distinct patterns in the Parkinsonian patient. There are pauser cells and there are burster cells. The pauser cells have an irregular firing pattern, and kinesthetic activity is not really found in Parkinson's disease, but there are some multi-joint kinesthetic activity found in dystonia. The burster cell is the other structure that's found. It has an interburst frequency that's generally slow of 1 to 10 hertz, but it has a high intra-burst frequency, 50, and it can go up to 300 hertz. The audio characteristics are squeaks. Then there are border cells, and these are cells that line the edges of the GPE and GPI structures. They're located at these areas, and they have spontaneous type of activity. Their firing rates tend to be about 5 to 15 hertz, with larger amplitudes, and the peaks are medium to broad. There's no movement-initiated response with these cells. The nice thing about these cells is it's indicative of when you're coming into or going out of one of these structures. Next, we get into the internal globus pallidum that lies medial and posterior and ventral to the globus pallidus externus. It lies lateral and anterior to the internal capsule, and there's a thin lamina between the GPI and GPE. There are two segments. There's the GPII and GPIE. There's the IE and there's the II. It does have kinesthetic activity. We do find different patterns in here. There are tremor cells and then there are high frequency cells, and it is very densely populated. It has rhythmic bursts of activity, the tremor cell of 2 to 6 hertz, and it's synchronized with visible tremor. The high-frequency cell, on the other hand, fires between 50 and 100 hertz, although it averages closer to around 80 hertz. There is kinesthetic activity. In Parkinson's disease, it's usually a single joint, where in dystonia, there can be multiple joints that are activated, that will activate that particular cell. Now, there are differing firing patterns depending upon the disease state we're in. So you need to know the disease that you're working on to understand the firing patterns. In Parkinson's disease, you tend to have a faster firing rate with these fast clusters. There's some areas of a little bit longer interspike intervals, but they're never very long. Whereas in dystonia, you see these very long interspike intervals, and there's nothing that really clusters as fast. Actually, one of the difficulties in dystonia is differentiating GPE from GPI. It's really those border cells that are very helpful. In Tourette's syndrome, you get kind of a combination of the firing patterns. I'm not saying the disease is a combination, but the firing patterns, to think about it, is a combination. You get these very fast clusters of firing, but you get larger interspike intervals sometimes. And finally, in status dystonicus, and this is a patient on propofol, it's a much slower overall rate that you do see in the GPI. The other area that we can come into is the optic tract, which defines the most ventral border of the GPI region. It's a white matter tract. It's a higher frequency. We're really recording the traveling waves along the optic tract axons. So it's not purely an extracellular unit that we're looking for. I think the characteristics are kind of a waterfall. And if you listen to it, you'll hear when it gets to about here, an increase in the overall amplitude of the activity. And that's the entrance into the optic tract with a flashlight faced into the patient's eyes. So in summary for the pallidum, you can see the different types of firing patterns for the different structures. In Parkinson's disease, it's relatively easy to differentiate the GPE firing patterns from the GPI firing patterns down here. But these high frequency cells in the GPI in dystonia can look like these cells in GPE. So it needs to be using these border cells that can be very helpful in localizing those structures. When we stimulate in those areas, there are adverse effects that we're looking for. If we're too dorsal, we can get poor motor control, and you may even get some depression, although that's not really found in the operating room. If we're too medial or posterior, we can be in the internal capsule and get muscle contractions. And if we're too ventral, we can get visual effects such as hallucinations or flashing lights. The next target we're going to talk about is the VIM. Here's an example of an electrode in the VIM. At its thinnest, the VIM is pretty small. It's around 3 to 4 millimeters. So the electrode kind of takes up a lot of the structure when you're in the optimal area for that. And this is about 15 millimeters off of midline in the sagittal plane in the Schottenbrand and Warren Atlas. The first structure we go to is the nuclei dorso-intermedii. It's a medium-sized area. There's relatively sparse cells. There is some movement-related activity due to some muscle input into it, although it's very hard to find when we're doing recordings in VIM. Bursting cells, slightly larger spindle-type activity, and it has broad peaks. Then we come into the nucleus ventrointermedius, or the VIM. It has large and medium-sized cells. You do get a kinesthetic response from these cells. There's a somatotopic overlay on this that we're looking for. There's deep pressure that you're looking for on cutaneous and musculoskeletal structures to actually help get this area to fire. So this is the ventral intermedius nucleus. It does, when you're stimulating, it can require large microamp currents to activate it a little bit differently when we have the larger electrode in there. And you do get some contralateral paresthesia sometime, and that's probably because you're bleeding the current into the ventral caudal nucleus, which we will get to. It's a noisy high voltage recording. There's a lot of cells in these structures. You do get recordings of kinesthetic and deep sensory activity, contralateral joint movement. If you squeeze the muscle bellies, you will get activity changes, and you do get tremor cells. Responses tend, though, to be found in the lower 2/3 of the structure, more so than the upper 2/3. And here's an example of just a standard background cell from the VIM. And now here's a tremor cell in the VIM. Then the ventral caudal nucleus we come to. It's large cells where the rostral part has a sparse distribution and the caudal area are evenly distribution. The fiber bundles radiate in an oblique dorsal direction. The rostral area, you get afferents from deep cerebellar nuclei and efferents to primary motor cortex. We're in the caudal region, which we're probably closer to when we're doing our recordings for tremor placement of electrodes. It's a sensory relay nucleus from medial meniscus, spinothalamic tract, and cervicothalamic tract. It responds to light touch with slow and rapid recruitment, responds to stimulation up to 300 hertz. So you can, if you stimulate the area, the patients do feel stuff. These cells have no fatigue. You can continually activate them. Caudal activity, although the lips sometimes will give you ipsilateral areas. The fields of the size of the fields for distribution of these cells ranges from millimeters for the distal phalange to centimeters for the trunk and leg responsive receptive areas. Here's an example, and these red arrows down here represent the firing, and you'll hear the increases in rate as we're brushing the patient's hand. So here's once again a summary of the thalamic area when we're recording. You can see the different firing patterns that we run into in those different regions. And that's how we can help localize to place our electrode in VIM. The final target we'll talk about is the subthalamic nucleus target. Here's an example of the electrode sitting in there, and this is at about 12 millimeters off of midline. Examples of the electrodes in the three planes, the coronal, the sagittal, and the axial plane. Here is the structures that we're going to encounter along the way into the STN. And the first area that we encounter is the anterior thalamus. It has a low firing frequency, low to moderate amplitude, bursters similar to thalamus and GPE, two firing patterns, single spikes and bursters. And the activity is dependent on patient arousal, actually, in this area. If they are more sleepy or asleep, you get less activity in this particular structure. The zona incerta we encounter after that, and it lies within the subthalamic region. Rostrally, the ZI begins at the level of the paraventricular nucleus of the hypothalamus, caudal extent to the reticular thalamic nucleus. It's a small gray matter strip below the thalamus composed of diffuse cell groups, and it's laterally continuous with the reticular nucleus. Some sporadic activity, and this once again is alertness dependent with a mean firing rate between 50 to 30 hertz if you do find a cell in this area. Breld's field, just as a side note, passes around the ZI, and this is communication between the GPE, GPI into the thalamus area. You get H1 and H2. It's really the H2 structures that we're recording when we're in below ZI and above the thalamus. It's usually a quieter region, that H2. The STN we come into, there are two types of cells. The standard high frequency cells can fire anywhere from 20 to 70 hertz, although it's usually between 30 and 40 hertz. High amplitude, because you're pretty close, these are larger cell bodies. A moderate background, minimal activity in previous pallidotomy patients though. We don't see many of those anymore, but early on when we were doing STN on the contralateral side to a pallidotomy, the activity would be different. And we also see tremor cells. So here's a high frequency cell. And here's a tremor cell. Now, one of the things everybody likes, those examples I gave you are just a single type. Inside the STN, each cell fires a little bit differently. It does have this characteristic, though, of these higher frequency regions in it, and that's really what we're looking for. This is probably the cleanest one over here, but the other ones are also STN cells. We next come into the substantia nigra, and it's the pars reticulata part that we're looking for. It has the pars compacta is really the part with the high concentration dopamine. The reticulata is more lateral in what we're entering. It has a high frequency firing, 50 to 130 hertz, a moderate amplitude, and the border between the SNR and STN can be very close. So you may not have a quiet zone. You may move from one structure right into the other structure. When we stimulate the STN, we look for some adverse effects also to make sure our electrode's not near there. If we're too medial in the structure or posterior, we may get paresthesias or other sensory phenomenon. If we're too anterior or lateral, we may get some motor contractions from cortical spinal tract. And if we're too dorsal, we can get some type of affective disorders from the nigra. And if we're really ventral, posterior, and medial, we can be into the ocular motor area and get some diplopia or other ocular motor phenomena. Now, here's an example of a kinesthetic cell. This is testing the patient, and this is the activity that we look for when moving the patient's joint. The other thing that we can do, and this is a patient with activity in the VIM, is get response to the patient voluntarily moving their limb. So in conclusion, the characteristics of the firing pattern, which includes rate, synchrony, density, and response to external movement, are what helps us in figuring out what structure we're in and localizing the optimum place for the DBS lead.